and 512 and positive with 1024.
With the retraction, can you visualize the ossicles? Did you mention about the ossicles? Even if you don't visualize, you have to mention it. You with the
Why it is common to examine with the 512 only? Like if you don't have all three, it's better. I mean, it's adequate to examine with 512.
So because it falls in the speech frequency, has an optimal tone decay, and it is more heard than the felt.
And the problem with 254?
It causes more vibration than the auditory. So
1024.
it has a tone, high tone decay.
Okay.
What exactly mean by tone decay? When you say tone decay, it means what?
When I unit on my elbow, bring it to the ear, duration of vibration is lost earlier in the 1024.
So why it is more with the higher frequencies?
Anybody?
Huh.
Why the tone decay is more
Yes,
with the
yes.
high frequency?
Please go ahead. Can answer.
Frequency is inversely proportional to the wavelength of the sound.
Okay. Yeah, so what happens?
So according to compression rarefaction, so more the frequency, less the compression rarefaction, for less time it will, more time it gets decayed faster.
Yeah. True.
It is the physics. Okay, the frequency, the 512, suppose 500 frequency, it moves more faster. But if it is a higher frequency, then it will be a slower in amplitude. So to reach to a destination, it requires a more time. Right? So whatever it is a condensation and rarefications. Sound created by this
A column
object
of
produces compressions, then rarefaction, compression, then so more frequency. If it is a higher frequency, to reach a particular destination, it require a more time. So it decays fast in time. Right?
ABC?
yes, absolute bone conduction test. It's equal on both sides, and Weber's lateralizing to the left side.
Are you comparing ABC on patients both side or someone else?
I'm
Absolute bone
bone
conduction
conduction
test has to be
compared
compared
patient,
with.
patient and
So you told it's equal on both side means what?
the absolute bone conduction test is equal in left ear when compared to examiner.
So it is
And
not
also-
reduced, not equal. It is not reduced or reduce.
Then, facial nerve examination. The patient has a left side grade 3 facial weakness present with complete closure of eye with maximal effort and slight weakness of mouth at effort. And obvious asymmetry seen. Rest of the cranial nerve examination is normal. Fistula test is negative. Examining the balance test.
How you do fistula test? How you do fistula test?
I will first fix the head of the patient and then press the tragus alternately, and we'll see the check for the nystagmus is present or not.
How does this tragus pressing? Yeah, only nystagmus.
A patient complain of giddiness. Nystagmus.
What is the other method? Suppose
Then
Sigillization or
sigillization. What you must be knowing, right? What are false positive, false negative causes?
false positive. It is seen in the congenital syphilis and also in the stapedectomy. And then false negative, it is seen in the dead ear as well as if it is a labyrinthine fistula plugged with a cholesteatoma. Then on balance test, negative Romberg's test, tandem walking, no evidence of any nystagmus, no evidence of dysdiadochokinesia, and fast pointing and finger nose test.
So you check for cerebellar signs as well. So tell us the all cerebellar signs.
Romberg's sign. Then Urtenberger sign. Then I have to
Or cerebellar signs. Cerebellar. What are the cerebellar signs?
Romberg's test, tandem walking, Urtenberger's test, dysdiadochokinesia, fast pointing, and finger nose test.
What's about nystagmus? What's about knee jerk? What is the kind of knee jerk in cerebellar signs? Pendular knee jerk. Good. All are signs.
On examination of a nose, patient has a
You haven't examined opposite ear? Normal. Well, just normal. You on one side, yeah. If the patient has developed cholesteatoma on the left side, how come the right side ear would be absolutely normal? So it is unilateral eustachian tube dysfunction that may have led to the retraction and then cholesteatoma.
You have to mention about the left ear also, all the things.
Opposite ear.
Opposite.
Opposite ear is absolutely normal. The drum is absolutely normal. Explain how come unilateral eustachian tube dysfunctioning? Is it possible that eustachian tube without any organic pathology, like in the nasopharynx causing space occupying lesion blocking the eustachian tube on either side, the patient is having only unilateral and opposite side is absolutely normal? Is it possible?
examination of the nose. The external skin of the nose is normal. On tip raising column, normal vestibuli and normal external nares. On anterior rhinoscopy, septum is centralized with normal nasal mucosa.
So you examine with anterior rhinoscopy. You have done anterior rhinoscopy? The thirticum speculum is to be held on right side, left side, what side?
Left side of the examiner's hand.
Okay. Why on left side? Why not right side? Why you prefer left side? Because you are lefty, or why not right side?
Where is the bull's lamp?
It's on the right side of the patient.
So how will you position your bull's lamp?
To examine the nose, I have to focus the air on the columella of the patient.
So what is the distance of the bull's lamp from the shoulder of the patient?
6 mm.
6 what?
It is about 18 centimeter lateral and above the shoulder of the patient. All right. Now the bull's lamp is convex or concave?
It is concave.
No.
Convex.
Convex.
Bull's lamp, huh?
Yes.
No. It is not concave or convex.
It is plano-convex.
It is plano-convex.
Plano-convex. Yes.
That's why it is called bull's eye.
Yes.
Anterior rhinoscopy, septum is centralized with normal nasal mucosa. Posterior rhinoscopy is normal. Examination of paranasal sinuses is normal. Oral cavity, normal. And examination of neck is normal. And no evidence of any lymphadenopathy. And my probable diagnosis is patient has a left chronic otitis media with active
You have done
squamous.
posterior rhinoscopy?
Yes, sir.
If you don't have mirror kept for posterior rhinoscopy, how can you comment about posterior nares?
It was there in the tray, examination tray.
Yes, ma'am.
Say yes,
Yes,
it was
yes.
there and I did it.
St. Clair Thompson's posterior
Oh.
rhinoscopy.
No, the name of posterior rhinoscopy mirror is not St. Clair Thompson. It is ideal mirror. The name of posterior rhinoscopy mirror is anyone from audience can answer. Those who are exam going and those who have not passed. The name of posterior rhinoscopy mirror is Mackenzie. St. Clair Thompson is ideal mirror. It's a bayonet shaped, no? Posterior rhinoscopies. If you don't have the mirror, then how can you examine posterior nares?
How will you do posterior rhinoscopy? What will you tell to the patient? How will you do posterior rhinoscopic
Explain
examination?
procedure of how to Then I will depress the tongue of the patient with tongue depressor. And by using a Savlon, I'll pass my posterior rhinoscopy mirror be, behind
You are
the
using Savlon for what?
to avoid fogging.
So you have to tell no that you
Ah.
will apply Savlon on the mirror.
Mirror,
Ah.
right.
Then
What is the
Then-
best method? What is the best antifogging?
Is the passing through the saliva.
no.
To prevent fogging,
Fogging.
what do you use and what is the best?
Ideally,
uh,
we
It is always hot water
Water.
or spirit lamp,
spirit lamp.
right? Spirit lamp is ideal.
And the mirror should be heated by what surface?
Heated.
Back of the mirror.
Back of the
not
mirror.
directly on the
Ah.
mirror.
Mirror upwards. Posterior rhinoscopy.
Up back. towards you. She said that we want to depress it. Why do you want to depress it? Look at the neighbor parents. We want to depress. What happens? Ergonomically, what happens?
Ergonomically, what happens in the oral cavity when you depress the tongue versus when you protrude the tongue?
To increase the area of the oropharynx isthmus.
One is the height of the
The oropharynx
oropharynx
is
will be more
more.
when you are doing
Hmm.
depressing the tongue. Second thing, what will happen? What will happen to the base of the tongue?
Posterior pharynx and the soft palate, there will be more space to.
The base of the tongue also will go down, right? And you ask the patient to breathe through the nose or through the mouth.
I will ask the patient to breathe through the nose
Why?
to avoid fogging of the.
To avoid fogging or
Fogging.
something. When the patient breathes through the nose, what happens? What
There will
happens?
be relaxation of the palatal muscle and
The
that-
soft palate will come down.
Yes.
So there will be more space into the nasopharynx, right?
Mhm.
Okay. And when you ask the patient to protrude the tongue in a case of IDL, what happens to the ergonomics of the tongue, to the larynx, to the pharynx, to the soft palate?
Ma'am, I would get a more space to introduce my.
Which space? Because when you're depressing, you were increasing the height. So by protruding, you will decrease the height of the oral isthmus, right? So still you want to make the patient protrude the tongue.
Because then the base of tongue would be advanced anteriorly, so I will
Yeah.
have a space to.
So when you are protruding the tongue and depressing the tongue, the larynx will move upward and forward. So you will get more antero-posterior diameter and the tongue also will come for anteriorly. So the antero-posterior space you will get will be more. The epiglottis will be tilted little anteriorly. So you'll be able to peep into inside the larynx.
Larynx.
So if you want to see the vocal cords and all, this is the ideal condition, right? Okay.
My probable diagnosis is patient has a left chronic otitis media with active squamosal disease with moderate conductive hearing loss with left side lower motor grade 3 facial weakness with no intracranial complication.
With no nasal or.
With no nasal or oral.
So what could be the reason? Suppose septum is centrally placed. It is matter of nothing. There is no obstruction in the nose. What is the reason of visual cholesteatoma?
Patient may have sometimes upper respiratory tract infection that impairs the mucociliary function of the middle ear. That leads to negative pressure in the middle ear and causes retraction pocket. But which does not get resolved.
See, otitis is 5 years, right?
Yes.
It's for the 5 years. So it is very long duration. So there has to be some obstruction in the nose or, in the UCN tube. When it is not properly functioning, then only. So the basic pathology lies in UCN tube, but nose is absolutely normal. There is no septal deviation, no obstruction in the nose. So what could be the reason for UCN tube dysfunction? That I'm asking. And it is unilateral. Other ear is absolutely normal, right? So what could be the reason?
Unilateral. If it is a bilateral eustachian tube blockage, then opposite ear must have some grade of retraction. You said it is absolutely normal.
Patient is only 30 years. Yeah, history is since 5 years.
Yeah.
So what will be the reason?
Just for 5 years, patient's ear has gone for a toss. What can be the reason?
From audience, yes. Other students?
We suspect that the only one side of the ear is involved, and we suspect that ET is not involved, and there is selective atic disventilation on where only posterior isthmus get blocked. So only atic disventilation.
But why?
why-
Selective
what would be the reason?
ventilation. Why would it happen?
Due to
Why
webs
should
and
this-
granulation formation
Because
over the ventilation path.
make that aterostasis happen.
No, but only one side, why it should be affected? If
Even-
everything in the channel is right,
What is the reason for that thing to happen? That the only a
Unilateral.
small pocket is there. What can be the reason behind it?
as simple as that, unilateral eustachian tube blockage, that's it, why and what?
So what are the causes?
What are the types?
That
of
I'm asking you for
blockages?
unilateral, yes.
What are the mechanisms of AGT blockages? Is it always structural blockages or
It is
anatomical
a
blockages?
general.
Or there is something called as restriction dysfunctioning because of fractures, because of dynamic blockages, because of the lack of mucociliary
clearance.
clearances. There are things like that also, no? There is a petular suspension tube too. But unilateral again.
Yes.
It can be unilateral, not necessarily. It can be. It can be. Like what must have, there are two theories behind this, why it should happen. These are very commonly question asked, and it is a hypothesis, nothing is proved as such, right? But we can imagine that, as she said rightly, patient might have had a very bad respiratory tract infection once, where one or ET might be more vulnerable compared to the other, and that had blocked for substantial time, wherein the most vulnerable portion of the tympanic membrane, which happens to be the posterior superior quadrant, must have been withdrawn inside, and there might have been developed some adhesions or something, wherein now that retraction, that area is not getting ventilated, and that time it was debris formation, but over long-standing retraction, the clearance of the tympanic membrane, which is outer towards the periphery and outer, has been hampered, and now a vicious cycle has been set in. That is why this is a reason. This is one very a theory where you can accept kind of believable theory. Second thing which might be possible, that there is a unilateral malfunctioning of the eustachian tube recently developed for some reasons, and then the whole vicious circle has happened without upper respiratory. Because in past also she is not given a history that patient had a upper respiratory infection. So to me, these are the two postulates for a happening of a unilateral
Eustachian tube dysfunction.
ET dysfunction. How will you proceed now? How to treat your patient?
First, I will go for audiological and radiological investigation for this patient. And for audiological, I would like to advise for the pure tone audio.
Direct audiology, no microscopic examination.
Which is better, autoendoscopic or microscopic examination?
No, in the routine OPD, auto endoscopy is convenient.
No. You have both in your hand. Auto and micro. Which one is better?
That's the diagnosis.
Yes, ma'am.
So now for further
Confirmation.
microscopic examination.
Is better or endoscopic?
Suppose you say microscopic, so why it is better?
And
Suppose you say
endoscopy.
why it is
Magnification.
which one is better for examination of ear?
Microscope is better because it gives the depth perception of the tympanic
Yes.
membrane and the cholesterol.
Is there any role of like autoendoscopy in these particular?
Ma'am, it gives a higher magnification towards the retraction pocket, so can be looked for the fundus and the
Investigation, other investigation?
would like to go for radiological investigation. HRC temporal bone.
Why HRCT? You have already some complication. You have already some extra cranial complication like facial palsy. Then HRCT is not the preference of CT scan. You need to go for some other kind of CT scan when you are suspecting some other complications. Already you have facial palsy,
Contrast enhanced.
contrast enhanced.
CT scan.
Will you look for?
I will look for the extent of the disease, the tegment plate, dural angle, dural plate, and the involvement of the eustachian tube, high raised jugular bulb. And if it is involved in the status of the cochlea and the oval window and the ossicular
Vestibule, labyrinth, everything.
So this patient has got a facial palsy, right? So what do we expect in your CT scan? In this particular patient, what is your expectation?
There could be a dehiscence of bony facial canal over the
Yeah, for a days.
tympanic segment of the facial canal.
Why does that happen?
Because it has only two ossification center, so there is more likely if there is any faulty fusion between the tube fusion in the tube ossification center.
Is it? Or kuch reason? Any other reason? Where is the most common cholesteatoma sitting place where so cholesteatoma is found? In the attic, in the PSQ.
Hmm.
So that is the most common area where the cholesteatoma is in contact. Is it the faulty ossification जिसकी वजह से ये हो रहा है? Is it some theory of a cholesteatoma which is creating bone erosion?
It is
Because bone
theory of
erosion in
the
cholesteatoma happens
that
in all the
causing harm.
places. So it is not that theory. It is the theory of cholesteatoma
causing
eroding the bone.
erosion.
Why the cholesteatoma erodes it?
Ma'am, the enzyme produced by the in the cholesteatoma that causes the bony erosion of the facial.
What are they?
Matrix metalloproteases 2 and 9, acid phosphatase, and
You say two, no? There are more others.
collagenase. हाँ. Yeah.
Protease.
Acid phos-
So only is that
You-
responsible for.
inflammatory mediators like tumor necrosis factor, interleukins.
Then.
Interleukins 1 and
And what is pathways for spreading?
Ma'am, there are three. It can spread to the posterior epitympanic. It can spread to anterior epitympanic, and third is posterior mesotympanum. Ma'am, when the cholesteatoma pass through the anterior pouch of Voltrecht, it can pass through the anterior epitympanic sinus space, and in posterior epitympanic.
It's comparatively less
lesser.
common. So we'll like to.
The head of the malleus sitting there, and there is the anterior epitympanic cord and the muscle which is sitting. So the anterior epitympanum is the most robust area in the whole attic, where because there is a cog also there. So there are a lot of bony things there, and there's a less of a air pocket there. So you finding a cholesteatoma is very, very rare. And if it is there, then we'll talk in the management. That is the most common area where you might leave behind a disease.
Yes, ma'am.
Right? So we talk about drilling the cog and all. We'll talk about it when we talk about
Hmm.
surgery.
In lateral epitympanic, it's spread via the posterior pouch of Voltrecht, then it enters through the superior incuidal space, and the cholesteatoma spread to the lateral to the attic and editus, and it passed through the editus and antrum. And another is through the inferior incuidal space. It goes to the medial to the it spreads to the sinus tympani facial recess, and to the posterior tympanic isthmus. Again, it goes to the attic.
It's called as a retrotympanic.
Retrotympanic.
One is a protympanic spread, another one is a retrotympanic space, and another third one is the epitympanic spread. Okay.
What is pathway of airway? How airway? Pathway of ventilation through nose into the ear.
Through the nose from the eustachian tube.
Through nose to pull.
The air from the nose passes from to the eustachian tube, enters into the mesotympanum. Then it goes to the anterior tympanic isthmus and posterior tympanic isthmus. More of from the anterior tympanic isthmus, it ventilates the attic area. And Prusak space is ventilated by the posterior pouch of Von Trosch. And from there, it goes to the editus and antrum.
Then
Some of the.
Then what?
And-
Then
With the inferior incudus. हाँ.
Yes.
Inferior incudus space.
Yes.
One.
does all the air get absorbed or some of it comes out? It's like this or it's like one way? You told is a one way. All the air that goes through station tube gets absorbed into the middle ear or some of it comes out?
What happens?
There is a generation of the negative pressure in the nasopharynx that causes
Some
the,
of air comes out or not?
yes.
It is a circulation.
Yes.
It is a circulation or a one way?
It is a circulation.
Yeah. If it is a one way, then imagine how much air gets stuck into the ear. Huh? It comes out also. That is a pathway complete. What are the boundaries of Prusak space you told repeatedly, right? What are the boundaries of Prusak space?
Superiorly, it is limited by the lateral malleolar fold. Medially and inferiorly by the neck of the malleus and laterally by the scutum and the pars flaccida.
Pars?
Flaccida.
Flaccida. I don't think scutum comes there, huh? Only pars flaccida, literally.
Okay.
What is the final treatment? You have investigated, right?
Yes.
Radiological, everything is
Hmm.
done. Is there any role of medical treatment?
No,
Because patient has recently developed facial palsy.
no.
So you will go for
Surgical management of the patient.
which kind of surgery?
Ma'am, I would like to go for the modified radical mastectomy with facial nerve decompression in this patient.
Is MRM, can you define?
Ma'am,
Modified
MRM,
radical
modified radical mastectomy is defined as an eradication of the disease from the middle ear cleft with making a common cavity for and a mastoid middle ear and the EAC, leaving behind the healthy tissue for hearing restoration, for further hearing restoration.
So on starting of your surgery, you are planning, you are sure that you are going for MRM only?
So you'll decide per operatively, no? Okay, what,
Yes.
looking into the ossicle.
For MRM only.
Okay, if you have to support your own statement, you have to justify this, yeah, I want to go in for, I'll end up doing MRM only. I don't want to go in stable as exploratory mastectomy and then convert it. What are the points in favor of going in for MRM?
If there is a disease,
You have a
Huh.
patient.
Presence of diseases in the facial recess sinus tympani and the labyrinthine area.
Patient
This is- हाँ.
Posterior
Posterior sinus तो तुम्हें पता नहीं है कहाँ है. Posterior superior cholesterol. Second, major reason why going for MRM.
Poor eustachian to function of.
No, that's not it.
Patient has already developed complication.
हाँ.
CAT or something,
Hmm.
your ET has to be functioning well.
Hmm.
So, okay, that point taken. Any third reason?
If there's reconstructable posterior canal.
Already it is
Complicated.
complicated.
हाँ.
Very complicated case. What is the other option if not MRM? What the other option you will have?
Combined approach tympanomasty.
What are the prerequisites of doing the combined approach tympanomasty? There are certain prerequisites. ऐसा हो तो भी combined approach कर सकते हैं. One is the ET should be functioning well. Second, your canal, posterior canal wall has to be
Healthy.
Healthy.
right? If at
It
all
is
there is
posterior
erosion,
cholesterol, so might be partially eroded.
yeah, if at all there is erosion, then
There is no point
the
of keeping-
amount of erosion has to be judged on your CT scan. If it is more than 1/3 or more of a canal wall erosion, then doing the CAT will be difficult, or you might have to plan your reconstructive policies. It's not that you cannot do it. You can do anything, but then you will have to reconstruct it. So how you are going to reconstruct that also, you have to keep it in mind, right? So your posterior canal wall intactness will decide whether you can do a
Combined approach
classical CAT or you will have to do canal wall down with the reconstructive strategies. And any other point where you will say that I'm going for MRM only or I'll not be able to do CAT. CAT is done for a limited cholecystectomy. What do you mean by limited cholecystectomy? How limited? Yeah, anybody? इतना कहाँ कैलकुलेस्टोमा होगा तो हम कैट नहीं कर पाएंगे. Whatever. कर पाएंगे नहीं कर पाएंगे. Let them say ना.
Emblema, retrofacial area, perilabyrinthine area, sinus tympanite and combined approach.
होगा तो थोड़ा difficult हो जाएगा.
Combined approach tympanoid mastectomy will be difficult in this way.
Right. So this is why even if there is no full complication, your CT is going to help you a lot. It will tell you how much big cavity you are going to give. If it is a canal wall down, you are going to do. It's going to tell you whether you can do intact canal wall or not. If you are planning for a canal wall down or intact canal wall, are you going to reconstruct the posterior canal wall by some means? If yes, then by what means? Both whether those materials are available locally or you are going to procure it. So all these plannings has to be done. इतना बड़ा cavity है ये है वो. In addition to that, you have to plan your surgery, right? So if MRM है तो एक तो PSQ में है तो sinus tympani में होगा, ossicular erosion होगा, facial no paralysis already है तो facial eroded होगा. With CAT also you can do a facial decompression. Rather nowadays it has been many years now that facial decompression means you have to keep the canal intact. In today's era, if you remove the canal and do a facial nerve decompression, that's not done thing now. You have to preserve the canal and then do a facial nerve. So this is how.
Again, it is if it is a cholecystomatous facial nerve palsy or it is a traumatic facial nerve palsy. Okay, if it is a traumatic, then obviously you should keep the canal intact if possible. Right, because where the incident tube is not at fault, it is a trauma. So we want to decompress the facial now only, keeping the canal intact. But in case of erosive or this squamous metaplasia is there, then if you are a junior surgeon, then it is better to go for the canal wall down. Even the aim of this canal wall down surgery is what? Basically, you want to see the each and every hidden area into the mesotympanum, epitympanum, hypotympanum, and mastoids. Now, with the invent of the endoscope, right? See, we are keeping the endoscope in the nose and you are looking at the most anteroinferior part of the maxillary antrum. So why can you do the same thing into the nose, right? So with the, in the ear also. So if you keep the, this disease removed from the conventional way of cortical mastodectomy, you can remove the disease. You are elevating term, you can remove the disease from the middle ear, and epitympanum. Now the problem is with if there is a deeper sinus tympani region, which is very difficult to keep the canal intact to remove it. So if the experienced surgeon is there and he can do the removal of the disease with the endoscope, then again, you can keep the canal wall intact. So as Madam has said, so there are all the ways that you can keep the canal wall intact, but it depends how experienced we are. And whenever the complications, please do not keep the canal, right? Because in the world ever, there are many experienced surgeon has performed the canal wall intact, but they always go with the MRI every 6 months for the recurrence of the remnant of the disease. And many a times, I can say 30% of the cases they have to revise. So what happened? The infiltrate cholesterol turn into the pearl. So that is very easy to remove it, right? But in our scenario, when the patient is not coming frequently for us, particularly in the civil hospital or district level hospital, so you will not advise every time for the recurrence MRI. So always go for the canal wall down. So at least whenever the recurrence or remnant, you can identify it.
On the medial wall of the middle ear, it is the process cochleoformis. The facial nerve is above and medial, and the lateral semicircular canal above and lateral.
So one is processes cochleoformis.
One of landmark.
Identification. Okay,
Then second is lateral semicircular canal.
third.
Then the pyramidal eminence, and
Anything in the mastoid?
tympanomastoid suture line, and the digastric reach.
Even when you
And
are
fossa
doing-
incudis.
Fossa incudis. Yes.
So how will you know that your MRM is ideal? How much you will lower the facial?
Flush to the facial nerve, vertical segment of the facial nerve will facial reach.
So what is ideal cavity?
Hmm.
Ideal cavity.
There are some M
Characteristic,
criteria
yes.
of.
So you can say it is ideal cavity.
With the sloping edge of the mastoid cavity,
Superior.
superior tympani, posteriorly up to the sigmoid sinus, and inferiorly up to the digastric ridge.
So you mean to say that
Landmarks.
you mean to say that you will extend it each and every tensor. Most of it. In ideal cavity, MRI. On ideal cavity, this is ideal post-operative cavity.
Common
There are some
thing-
points. Yes, what is ideal cavity? Anyone from the other students? Yes. We talk about the shape, the boundaries.
Smooth, self-cleansing and extra is a cavity in which we can see the whole cavity with one view of endoscope, one view of otoscope.
That is post-operative, on table,
on table.
That's good. Post-operative, that is ideal cavity, where you should be able to see without the pacular, in the bullseye or the head mirror. And without any instrumentation, it should be the posterior wall of the meatoplasty should be flush with the posterior wall of the cavity. The superior should be flush with the superior, the inferior should be flush with the inferior. It should be well epithelialized, and it should be self-cleansing. There is no severe reaction on that. So usually it is not self-cleansing, and the one of the disadvantage of a canal wall is it is the surgeon dependent cavity. Every 6 months, 10 months, patient has to come to a surgeon to get it filled. So it is usually not self-cleansing. That is the post-operative criteria for a good cavity. But you are sitting on the table and you want to know that whether what I have done is a good job or I am still yet to achieve that. So what are those things? Yes,
Smooth, shallow, well sutured without any residual.
yeah, it should be round in shape. It should be sloping edges means well socialized, right? There should not be any residue. There is controversy of all diseases, all
air cells.
extension limited, but there should not be any disease left behind, right? That means you have created a good and later you have to do a good wide meatoplasty. As I said, the criteria for a meatoplasty, right? Adequate meatoplasty, किसको कहते हैं? एक अंगूठा जाता है, दो अंगूठा जाता है, nothing. It should be flush with all the walls. When you see on the table, you should be able to see and on view of the whole cap. That is on table, it's a good cap. Later it's going to contract a little. So your meatoplasty is going to be a little smaller, but at the same time, even the cavity will become sad and everything will fall as you had seen on the included. So that is the ideal. What are the ways to obliterate the cavities?
How will you obliterate the cavity?
It could be fat, cartilage, bone.
Fat का मसला होगा.
Why you want to go far when you have available
Hmm,
nearby
then the,
solution?
What would be regular?
Muscle flap superiorly. Temporalis fascia, superior based temporalis muscle.
Muscle.
Temporalis,
Then
temporalis muscle,
temporalis muscle based on which artery?
uh, superior temporal artery,
Or middle temporal?
superior temporal artery, superior. Middle temporal artery is a branch of the superior temporal.
Temporal is a branch of superior temporal.
Ah.
We see this temporalis muscle with fascia or without fascia?
With fascia.
With fascia.
Patient have already taken with the grafting. You don't have patient.
Ma'am, we have taken a limited.
Already taken. What he told me, that the same muscle you're going to turn, same place same liya hai. Because the one which is accessible for taking to graft, that muscle only you are going to turn. You're not going to go up and turn back.
Yeah, so it is
With
without
the
temporalis
fascia. Fascia.
One is muscle, second is you are drilling. So what can it be else?
Bone wax.
Yes, very
Bone
good.
wax.
Second is bone wax.
Then cartilage.
Then, then,
Cartilage.
yes, cartilages. So that is
And
Biomaterial.
from lower side, inferior side,
Sternocleidomastoid.
lymph
Occipital artery. Posterior auricular. Auricular.
Valvascular.
Mm. Anterior leaders.
Or of muscular cortex.
Yes.
Advanced.
So you can, if there's a smaller cavity, you can use that, too, right? When you're doing neoplasty and removing all those subcutaneous tissue and muscles, you can just rotate it inferiorly and fill it up. Now you.
So what is the difference between cavity lining and cavity obliteration? There is some, terminology like cavity lining. And second is the cavity obliteration. What is the difference between these two?
The word is self-explanatory.
lining the cavity by
Must.
what would they look now common?
Cavity lining matter, which material is used?
We use the inline cavity.
Hmm.
Graft.
Fascia.
Any patient, pericon, right?
Everyone you can use epithelium.
Yes, you can use epithelium also. Now you told me that there are no ossicles. So what do you think? How will you reconstruct the hearing of the patient? Or operatively, suppose
Like if you step his head and no other obstacles. Then what are it of possibility?
I would like to reconstruct with the cartilage,
Which part is
tragus cartilage.
Why do you want to take a tragal cartilage? When
so you can use a concal also. You are already putting the incision posteriorly. You can use all
What are
right.
the advantages of tragal? You are right. You will prefer tragal cartilage. What are the advantages of a tragal cartilage?
It is
We have been using both, right? You have seen the advantages, disadvantages of both.
For transcanal, it is beneficial because there is no scar mark
Hmm.
seen बरोबर, in tragal cartilage. But here you are already using the post-oral, so you can use the concal cartilage also.
It's a tragal cartilage. You'll prefer tragal
Hmm.
cartilage even when you are doing a post-oral. What are the advantages?
because the
of tragal?
concal cartilage has the convex.
And it is a single. So are there any chances of periconditis?
Periconditis and hematoma on the.
All right.
That you will cover it up. The thing with the concal cartilage is very robust. It's very tough. So when you want to reconstruct it with the tiny ossicles, it will be very difficult for you to mold
Manipulate.
it. Whereas in case of a tragal cartilage, it is soft and supple. So it will bend the way you want. So that is the major thing. For
I think that can be there.
yeah. Okay. So even when we are doing postural, most of the time we take a tragal cartilage. Right. Okay.
If not cartilage, then what are the other modalities? Like normally you are not doing it with other things, but what options you have available when you have a static suprastructure?
I can use partial ocular restriction
Or
for
what are the material commonly used in making for
Teflon and titanium. Titanium.
titanium? You should,
Gold भी आ रहा है.
you should be knowing that two tables.
Gold.
And you can use bone also. You can remodel the bone and put on the stapes. All right. Yes. Yes.
Bone remodeling.
Is avoided. Because,
So first we'll talk about the autologous graft and then you will talk about the homologous graft, right? That way you will prepare your answer. Whatever is available in autologous, whatever is available locally, that you will use. If not, then you will go for a septal cartilage or a rib or something. You have so many options there, right? Okay.
What are the advantage of using this all the pork material? What the status? You can keep a graph over the status in case of canal. Why we use pork material?
To increase the space of between the graft and the middle. The height of the middle ear.
to increase the middle.
Why?
Happens. How it gives an advantage?
Why do you need same way, put in a different way, why do you need to have a bit of space? What is the importance of a middle ear?
For better hearing and impedance matching.
Why better? How does it help in better hearing? When you having a shallow middle ear space versus you having a no middle ear space or having a normal middle ear. Like when you do a type 2 tympanoplastics, all type 2A, B, C, जो भी करते हैं वो, you reconstruct your tympanic membrane, neurotympanic membrane at the level of the annulus. The moment you go inside, from the annulus inside, that is a shallow middle ear space, right? So how this middle ear space कम हो जाता है, तो how does it deteriorate the hearing?
The phase difference. Phase difference between the round.
But वो तो छोटा कम middle ear space होगा तो भी नहीं होगा.
But the
The
impedance.
importance of is asking about why middle ear space has to be as limited as possible.
Should be
Phase
as
difference is
normal
different
as
also.
हमारा impedance matching
Matching
mechanism जो है उसमें is there any role of volume of the middle ear, right? Middle ear air का volume जैसे बढ़ जाता है तो क्या होता है, कम हो जाता है तो क्या होता है? As the air decreases in the middle ear, the amount of vibration which will happen into the ossicle will be less. If you have a normal middle ear space, you will have a normal vibration and your hearing will be normal. The moment your air, मतलब किसी भी चीज को पिलाना है तो ज्यादा एयर होगी तो ज्यादा ही लेगा ना, सिंपल सी बात है ना? So that is why we need a normal middle ear volume of the air, right? That's why we try to create a middle ear neotympanic membrane at the level of the annulus. Always we try. नहीं होता तो it's a different thing. But we always try to create, and that is why the height of the, we say that we create a height of the ossicles. So that is what is the height. Because we are sitting down, the patient is lying, so that is the height. It is going laterally. But in our perspective, it is the height of it, right?
And on pork directly you put graft.
No, sir. We will put a chip of cartilage and then
Why?
to prevent the extrusion of the pork.
Prevent the foreign body reaction, accidental explosion. And putting cartilage on the pork is called as what? What is difference between interposition and transposition? You sometimes it is used interposition and sometimes it is transposition. What is the difference between this?
The word is self-explanatory again. Yeah.
It is
Sir,
placed.
the position in which we have between the two defects, we have to place some material, and in transposition, we have to just change the position of the skull. Some structure is attached to the main part.
Yes.
So you change the direction and you interpose it, you put in between the two something. So what cartilage we are putting is interposition. Between the port and the port to be and the impediment. Right? Why that cartilage doesn't get excluded? So the time when cartilage does, and the port or taut does.
Because the cartilage has the property of resorption. And
Resorption. Because the problem of the it's not the whole body of the fish. It is not about the body reaction will not be there. However, the torque and port is going to be bio-inert. But जितना भी bio-inert हो, अपनी body में इतना कुछ नहीं होगा, है ना? So that is why you put a small piece of cut. And second thing is, this torque and port, most of them are either of a metal, gold and titanium or something, or they are plastic kind of, Teflon kind of thing, right? So they are very sturdy. They are very rigid, I would say, not sturdy, I would say. And the neotympanic membrane which I will going to create is a very thin. So there are, and it's mobile, yeah, that is also another reason. So every movement is going to go in and out, right? So there is going to be a lot of brunt on your torque and port. So over years, we had given a dissertation and almost 100% of the torque and port had come out. And that is the reason that people have stopped using less of the torque. Even when you put this, right? So that is why the interposition of the cartilage is the most important torque.
Another advantage of this interposition is the surface area. Okay, when you keep the graft, one, what she has already mentioned, the length is increases. Another is the surface area. So whatever the sound through the external auditory canal reaches onto the drum, that is transferred through the cartilage, more surface area of this, whatever we have kept that up, and to the head, right? So it receives the sounds energy from broader area and it transmits to the lesser area. So more energy, sound energy passes to the inner ear. So that is the two main advantage when you put graft directly over the stapes, or you put something pork material and you keep the graft. So those are two advantages.
What are the complications that are associated with the MRM? What possible complications you can encounter while doing modified radical mastectomy? As you are going to do that now,
damage to the dura.
how will you know that you are approaching dura before during surgery? Dural damage will not suddenly occur. There is a sign that now the dura is going to come.
On drilling, there would be a hue of reddish.
No, usually you will have some bleeding in that area. Then it means that you are very near to the dura. So that it can be dural injury. Then,
Sigmoid sinus.
all right. Okay.
You started drilling, right? So you start drilling from where?
Mike Evans, right? 1.5 centimeter. In the floor of the antrum, I would, there is the presence of lateral semicircular canal. In fossa and fossa incudes. Plate superiorly, posteriorly up to the sigmoid plate and inferiorly up to the digastric ridge.
And Madam Chitra, how do you know that the patients are about to enter into the dura now?
When there is a bleeding during.
Yeah. Okay. Same for the sigmoid spinous. How will you know that the sigmoid is going to come out?
Bluish hue will be seen while drilling.
Change will come, right? What is the sinodural angle in this case? What do you mean by sinodural angle? You will reach into the sinodural angle.
It
So
is
how do you know
the
that
angle
you reach
between the dura
sinodural
and the.
Huh?
It is an angle between the dural plate and the sinus.
But how do you know that there will be merging of the
Dura and the sigmoid sinus.
Right, so that is a sinodural line.
What is the importance of it? What is the importance of the Trotman's triangle?
Uh,
What is a
Trotman's triangle. Posteriorly, it is bounded by the sigmoid sinus, superiorly by the superior petrosal sinus, and anteriorly by the bony labyrinth, and through which we can enter into the posterior cranial fossa.
Yes, very good. So the infection from the middle ear can go into the posterior fossa. It is one of the entry to it, and it is also an approach to the posterior fossa. One of the.
Then how will you go ahead again? You have reached the tegmen, you have reached the dura, you have reached the sinodural angle. The dome is right in front of you. Now what?
Then I would like to go for posterior tympanotomy and enter into the middle ear.
You want to do when you're planning for a cat or you're planning for MRL?
As it
we
is
are-
already,
Madam,
yes, ma'am.
So the complications, if you go, first of all, you can have an injection facial nerve paralysis if you are doing under local anesthesia. Secondly, once you open it, you may have you may go into the false antrum. How will you know that this is antrum?
That is, she said.
She said that it is a facial short process. So you have an instrument in your tray that should, yes, why it is known as an antrum seeker.
Seek before.
So it rotates 360 degree in the antrum. So you confirm it that it is an antrum.
Nowadays, we don't have an antrum seeker on our trolley. Why not? What is the disadvantage of using an antrum seeker? Nowadays, we don't use antrum seeker.
Yes.
Yeah. Because even we had learned, we never used antrum. So why
But that is theoretically.
not antrum seeker? Because you have to widen the editus edentrum. You have to see the short process of the incus. You have to see the incudomalleolar joint. And then you have to find that it is going into the editus edentrum. Seeking the antrum, using the antral seeker is a blind procedure, but that can lead to more vibration and thrust on the stapes and can lead to sensory neuropathy.
Yes, that may be their theory, but the instrument is that we are using in the mastoid. We are not using in the middle ear. It is just exploring only in the antrum, which is the big air cell. We are not going anywhere away from it. Now, can you tell me which are the other air cells? We'll go to it later on, but which are the other complications associated with it, with MRM? Now you can go to the ossicles.
Damage to
Then
the
your cortical mastodectomy is completed now?
yes.
What are the boundaries of cortical mastodectomy?
Superiorly, it is up to the tegmen blade, posteriorly up to the sigmoid sinus, inferiorly up to the digastric ridge, and anteriorly to the posterior canal wall, and medially up to the lateral semicircular canal.
SDL. And anterosuperiorly?
Anterior superiorly up to the fossa.
You should be able to see the
Yes.
short process of the
Hmm.
incudomalleolar joint. Okay, now how will you go ahead? Cortical mastodectomy, go ahead.
Then by elevating the TM flap, I would like to enter into
So
the
you want to elevate the TM flap after doing the cortical mastodectomy?
What we do routinely,
initially we check the ossicular status by elevating the TM flap and entering into the middle.
Status is not checked, that's why.
And the disease X.
Anybody?
Why you elevate TM first and then go for mastodectomy?
This side of medical. What?
TM flap, why TM flap you elevate first and then go for mastoid opening?
Yeah.
By elevating the tympanometer flap, if there is a small retraction pocket, and we can know the extent of the pocket.
You want to confirm your diagnosis.
Yes.
Whether it is really a cholesteatoma or just a debris which you can just clean it up and they don't need to do anything further.
Yes.
So you can want to pause it up, find out whether there is real cholesteatoma or not, if it is real or perforation or not. And by after elevating the flap, whether you can clear up that disease or not. If you can clear up cholesteatoma, you will clean the whole thing, right? And then you will see the ossicular.
Yes.
Right, so you will first do the microscopy examination without elevating
With the
the
micro-
flap. However, you have done an autological examination, microscopy examination pre-operatively, on table you will do
Remove
that.
the hand.
And then you will elevate the
Tympanic major flap.
You will confirm everything and then you will go in for a post-oral incision and then they do the rest of it, right? अभी क्या करोगे? You will 140 master now next. You will elevated in the chemistry trauma. You're not able to clear the disease by just sucking it out. To drill a lot of things and then you will be able to, how will you go about it?
Then I would go for canal wall down.
Then you will decide for a canal wall down, or maybe canal wall up, we do not know, but in this case, canal wall down. Okay, what will you do?
Start drilling the bony meatal, posterior bony meatal wall.
Start from the
Lateral to,
yeah.
What is the difference between ridge and ridge?
ridge is the bone lying over the vertical segment of the facial nerve. Up to the mid,
Start from there, hands.
Lateral to the horizontal.
Ridge, and you will be able to observe ridge.
It is the superior bony canal wall lying lateral to the ossicles and the horizontal segment of the
Extending from right to left.
anterior buttress to the posterior bony canal.
Covering up to
Horizontal facial.
ridge is from the
Medial tympanic sulcus to the left. Bony meatal wall post.
master T.
T.
Shallow master.
Correct.
After the master tape, occasion you might have to drill it up in that case, the silent master.
Yeah.
But the master, that is the inferior most boundary. Superior most boundary will be the process of incus, medial most boundary will be the annulus, and lateral will be from the lateral to medial. That is the boundary. So you started drilling from up down, yeah, down,
Up down.
up down, and lateral to medial,
Lateral to medial. Lateral to medial.
anterior to posterior, posterior. If at all, you have to clean out sometimes, like if there's a lot of bony overhang in the retrotympanum, you might have to.
Posterior to
Anterior. Mostly the facial now will be much posterior. So it will not very posterior, right? Okay, so you have drilled the bridge, you have drilled the ridge. And you already said that you will drill the lower the ridge up to the level of the facial
ridge.
vertical segment of the facial canal, bony canal, right? How did you know that the bony canal has come? Facial has come?
Ma'am, along with the nerve, there passes the vessel of the facial nerve, the U of.
Before that? Before that? वो vessel कहीं से तो जा रहा है, so you will get a sometimes little bit reading here. And how do you know that? What is it called as? Thinning of the facial canal is called as, there's a word used for that.
Saucerization. Skeletonization. Facial nerve.
It's called an eggshell thinning of the facial canal. It's like a egg. मतलब egg में inside tuck करते हैं तो टूट जाता है ना, उतना thin हो जाए, it will be so transparent that you will be able to see the facial vessels going on. The facial seat आपको दिखेगा, but still, howsoever thin you have done, there will be a thin layer of a bone on that. So that is what is called as the eggshell thinning of the facial canal. Okay, so you have drilled up the facial canal, you have removed the facial bridge, right? Now what will you do? अभी क्या करोगे?
Eradicate the disease from the hidden areas like sinus,
But
tympanic.
when you are drilling the bridge, removing the bridge and the ridge, if the IS joint is intact, are you supposed to do something? Is there any chances of you hitting the incus and hitting the secondary to vibration of the drill? So
Then
you will
remove the
dislocate
with the
that
ossicle,
incus. So
IS
that
joint.
is that examine the ossicles. If there is intact ossicles, you will drill. You have to first dislocate
With
the
the
IS
IS
joint and then you drill so that you will not transmit your vibration into the inner
Inner
ear and you will to sensory ear. Okay. So
What
you
are the
drill-
types of mastoid as well?
Antrum, largest hair cell, then periantral cells, perifacial, sino, perisinus, retrofacial, then tip cells, then zygomatic cells, peritubal cells, keraticocochlear cells, pericarotid cells, then supralabyrinthine and intralabyrinthine. Retrofacial and the perilabyrinthine cell. Facial recess and sinus tympani. Anterior tympanic, protympanic. Sinus tympani, it is bounded superiorly by the ponticulus, inferiorly by the semiculum, and laterally by the vertical ridge, facial ridge, and medially by the promontory, and posteriorly by the posterior semicircular canal.
How to examine the sinus tympani?
Endoscope to look for, depending upon the depth of the sinus tympani.
If you don't have, I mean, in previous era, you had no endoscopes available, especially the angulated one. There is some mirror. Huh? No, mirror. Penis mirror. Yes.
Or smaller size of PRS mirror, you can just put on the promoter.
Yes, and reflect. Yeah.
Yes. But nowadays you have endoscopes, clicker endoscopes, so they don't take historical difference. What are the causes of post-operative discharging cavity? Last question.
Due to the secondary infection, then
Common causes of discharging middle ear operated cavity. One is
Non-ideal.
non-ideal.
non-ideal if there is a high ridge, facial ridge, then incomplete canal wall down with mastoid molar. So, disease, plastic in narrow meatus. Plastic.
Saucerizing, round test. Proper saucerization.
So this was second last question. Last question is, what are the 4 Ds in operated cavity that led a lot of surgeons to do canal wall up surgeries in comparison to down?
Dependency, deformity, deafness, discharge.
Good result.
Thank you.
What of that? 11.
How did you all find this? Hello? कैसा लगा? Worth doing or not worth doing? We should have more of this.
अडार पहला तो हारोज घेतला. सोल अडार.
Anyway, at the outset, I thank all the participants without whose help this would not have been possible. And this has become possible because of all interaction from all of you and all the faculties, all my colleagues. And look forward that we'll have more of this kind of a teaching sessions. The exams are coming up very shortly. And if anybody is interested, I am available 24/7 to nahi kahungi, but morning 8 to night 10 p.m. You can contact me anytime. I'm ready to spend maybe 2 hours, 3 hours on Saturday, Sunday. We can sit together and discuss. Even most of the faculty also will agree if they want to join us, right?
Any question from you guys? That would be the last question.
Any question?
कोई क्वेश्चन નથી
जो
એનો
question
मतलब તમને બધું આવડી ગયું?
जो भी क्वेश्चन पूछे और जब आंसर हमने भी नहीं किया, आपने भी किया, ऐसा कुछ रह गया? Something to read for us. Okay, so all questions are answered, right? And thank you, Bharat Seeram, Pankaj Bhai, for putting this up. It was a great show, and looking forward that you will help us and support us in future too. Thank you, everyone.